Hello and welcome to this short video looking into a systematic and a simplified approach on dealing with hip pain in runners. This is from part of the series from the Running Rehab online course with Physiotutors. So in this video, we'll be looking at a general overview, looking into some key differential diagnosis, and also looking into a simplified approach on how we can tackle a complex region like hip and groin. Most therapists find this area quite challenging, and it's sort of called as the Bermuda Triangle in sports medicine. Hip pain in young adults is generally characterized by non-specific symptoms and often presents a diagnostic dilemma. Obviously, a comprehensive subjective history can help to narrow the differential diagnosis, and therefore it's having a systematic approach in dealing with this, especially in the endurance population. A detailed history should include the following: patient's age, any incidents of trauma, previous hip and issues, childhood hip disorders, onset of symptoms, nature of pain, location of pain and referral patterns, history of previous bone stress injuries, previous injuries or surgeries, presence of mechanical symptoms like snapping, popping, clicking sensation, stiffness after running, recent changes in training levels, and any underlying rheumatoid conditions or systemic factors. So that's sort of some of the key points which you take from the history. And one of the major difficulties we have with hip is we can't really palpate it. So suppose you get a runner with knee pain or ankle pain, we can palpate it and look for joint-like tenderness and see whether it's intra-articular or extra-articular. And that can be quite challenging here because we can't really palpate the hip joint. It's quite deep, and the surrounding muscle layers and the complex interaction of the neuromuscular mechanical factors. So the history is crucial. So, and also hip and groin pain can also be referred pain from the spine, gynecological condition, lower abdominal pathology. All this, both MSK and non-MSK, can also lead to pain in this region. And when we talk about hip pain specifically in runners here, and this is a recent retrospective case control analysis looked into 550 injured runners. About 49.6 was females. They all had medical diagnosed running related injury. All of the runners had undergone a treadmill analysis to see their foot strike pattern, vertical ground reaction forces, and injuries were classified by a recent consensus statement. So they looked into all those injuries, and what we can see, there's a sort of a gender bias. Females are 2.2 times more likely to come with hip and groin pain. Males are more likely to come with Achilles injury. And the foot strike as well. If it's more a midfoot strike, it increases risk of Achilles. Forefoot strike increases posterior lower limb injuries. And since we're talking about hip injuries here, and this sort of matches what I see clinically, is most of the patients who come with hip pain are generally female runners. So there seems to be a predisposition to hip and groin pathologies in female runners. And we briefly mentioned about the importance of history. So this is really nothing unique, just not for hip, for any running related injury, is taking that detailed history on training load, previous injuries, and the type of loading effect. So we'll go through one by one. So we know one of the strongest risk factors for future injuries in runners is history of previous injury. We want to look into things like stress fractures, chronic tendinopathy, major accidents, long bone fractures, and also looking into things like a current training volume. What are they doing, both running and non-running related? Are they doing any cross training? Are they doing high intensity training outside running? And how is the recovery like? And have they had any changes in the training volume the last 3 months in the intensity, volume, type of train on shoes? And how do they describe the pain? Can they localize to a specific spot? Can they put the hands on the greater trochanter and say it's more around there? Or is it a bit more vague in the anterior or groin? Or is it going into the thigh region? So generally vague pain generally means it's more likely to be intra-articular. A localized pain generally means it's more soft tissue involvement. And how is the character of the pain? Is it something which improves? Does it warm up, or is it worse the next day? Do they limp? And is it bad enough for them to stop training, or is it more like they have to modify it? And how is the irritability? Do they have any resting pain? Do they have night pain? Do they have limping? How much can they sit without pain? So all these factors will give us a bit of an idea and what sort of pathology is driving the patient's symptoms. And also with female runners, we have to look into screen for readiness, making sure that, what's the BMI, is it less than 19, what's the eating habits, if they had a history of bone stress injuries, previous stress fractures like tibia, metatarsals, or any femoral fractures. So I've spent a whole section on subjective and objective for more than 3 hours on the module. So this is just a brief taster to know the importance of having a detailed and subjective assessment when you're dealing with this sort of complex presentation. Now, to simplify it clinically, we can sort of put that into simple 3 groups. So I follow a 3-step process when I see somebody with hip pain in runners in a clinic. First is, we don't want to miss red flags. So I recently wrote a blog for Physiotutors where I go through how not to miss stress fractures around the hip and groin region, especially in a female runner. So if you're interested, I go through all those risk factors, and also previous history of cancer, because we know next to the spine, the most common region for metastasis is around the hip and groin. So we want to make sure if they had previous history of breast cancer, and also any systemic factors as well. So red flags generally is something we don't want to miss. Second is extra-articular involvement linked with training errors. So most of injuries I see are not sinister. They're generally because of overload. Usually the muscles involved are the hip flexors, TFL, GTPS. So generally these are something which you see like with any other running related injuries. So pain is focalized. There's a history of training errors, and we do appropriate diagnostics test. We can sort of confirm the diagnosis. But if the symptoms are vague and non-specific, and especially if they've been going for more than 3 months, that will make me highly suspicious that it's coming from the hip joint. If the patient is sort of 40, 45, 50 plus, more likely to be early manifestation of osteoarthritis. If they're fairly young, like 20s and 30s, that could be either by hip impingement or hip dysplasia. Hip dysplasia are more common in women than in men. Another common concern is it coming from the lumbar spine or referral pattern? So things can get a bit mixed up. So we're going to differentiate between 3 factors. GTPS. So suppose you get like a 47-year-old female runner who comes with the lateral and back pain. So we want to see, is it more GTPS? Is it more hip OA? Or is it more lumbar spine referral? So a typical patient with a gluteal tendinopathy, they'll have pain with walking, running, stairs when they have lying on the side. Palpation generally is positive, and the derotation test, resisted abduction, all of those things can reproduce the symptoms. And the diagnosis can be confirmed with ultrasound or MRI, although GTPS is a clinical diagnosis and most patients don't need an imaging. In some patients, it could be the early manifestation of hip OA. So is it like more a stiffness related? Are they complaining of difficulty in putting shoes and socks in the morning? Are they having sort of vague referral pattern more going into the thigh? And the hip impingement tests, provocation tests are generally positive, like the FAIR test, the Faber test, the Faber distance test, active SLR, all those things which irritates the hip joint are generally positive. And a simple weight bearing X-ray AP can generally pick this up. Most of the presentation of hip OA is generally after 60, but in some people who are predisposed, or people with underlying morphological variation, or people with childhood hip disease can develop hip OA much earlier in their 40s or even in the 30s. So it doesn't always happen to elderly people. So you do get a significant amount of patients who have hip OA symptoms in their 30s and 40s and early 50s. And something we want to always keep in mind is lumbar spine referral. Is it coming from the back? Are they getting pins and needles, numbness, range of motion restriction, positive neuro test? And if it's a more spinal related, that can't be picked up by an X-ray, they usually might need an MRI. And we have to be cautious here that there's a massive overlap here. So a lot of chronic pain, low back patients do have GTPS, and more than 40 to 50 patients with GTPS also have low back pain. So there's a bit of overlap here, but main thing is knowing which is the primary driver. If you're suspecting more intra-articular, they might present with the typical C sign, the deep pointer sign, and the triangulation sign, which I go through on the course. And that sort of will give you an idea whether it's more deep-seated. And as I mentioned, the most common is either OA, hip impingement, or hip dysplasia. A common concern which you have with runners is their concern that they might develop osteoarthritis, which is not true. If you look at the evidence, just like the knee, there is no direct evidence that running causes increases your risk of hip OA or future hip replacement risks. So we have to reassure our patients that it's totally safe. Obviously, we need to control the symptoms, get them stronger, and have a greater return. But running itself is very safe, and we need to encourage that to patients. And in fact, many of my patients who even have mild OA, we can continue with them running with appropriate modification and appropriate rehabilitation. So OA itself is not a contraindication, and in fact, it's really beneficial for the physical and mental health to keep them running. So that was a bit of a small taster on different options of managing and approaching hip pain. So taken from 40 hours plus of practical content, which which we launched recently with Physiotutors. So you got access to PDF forms and assessment, gait analysis. All the tools you need for a clinic is here, and we're really touched by the feedback where clinicians are finding it really useful. And so if you want to check it out, it's at study.physiotutors.com. I'll put the links at the bottom of the video. And you also have 48 hours trial period if you want to see. And there's high quality studio videos coming from Physiotutors and step-by-step rehab progression in all major running related injuries from hip, foot and ankle, and knee, and return to running, and comprehensive gait analysis and retraining. Thank you.